BC's recently developed some protocols that allow for recreational fentanyl to be prescribed to children in the guise of safe supply. What are your thoughts on this?
Dr.
And when you look at the
has also
denominators,
stated that some of her patients who get safe supply hydromorphone from your program have housing but choose to sleep outside Chapman's pharmacy intents to be first in line to get the prescription in the morning, which they often sell so they can buy illicit fentanyl. Some of these patients are vulnerable women who are being pressured to secure as much hydromorphone as possible so that their spouses or pimps can confiscate the drugs for resale. These patients also claim that the criminals wait outside their pharmacy and intimidate vulnerable people to hand over the hydromorphone. What do you have to say about that?
I would say that Dr. Koivu tells a lot of stories. Another story
You're discrediting another doctor. Is that what you're doing?
I am saying that what she has shared with you is not accurate in my experience.
This Guy's Garage. Like and subscribe.
Today's meeting is on the opioid epidemic and toxic drug crisis in Canada.
And I explain the problem of fentanyl variability to my patients by using a metaphor that compares fentanyl batches to a batch of chocolate chip cookie dough. If you don't mix the cookie dough well enough, you can end up with a cookie that has 2 chocolate chips or a cookie that has 20 chocolate chips. And the problem with illicit fentanyl is not knowing whether you have 2 fentanyl chocolate chips or 20 fentanyl chocolate chips. And by providing people with a prescribed safer supply of an opioid of known dose and known purity, they always get the same standard safe supply cookie of 10 chocolate chips.
New information has recently been released that corroborates previous reporting that there's mass safe supply diversion happening near the Chapman's pharmacy close to your clinic. Are you aware of this diversion near Chapman's pharmacy?
A question for you as well, Ms. Goodridge. What evidence has been released showing this?
It was in a series of tweets from one of the journalists, Adam Zivo, and it was put out already today.
Okay. So, I mean, safe supply clinicians, we rely on good research and published evidence and not on anecdotes and tweets on the platform of social media, Twitter X.
Okay, thank you. So, are you aware?
Excuse me, Ms. Goodridge, if she had more, we'll give her another 20 seconds, please.
And so Mr. Zivo is a columnist for the National Post who has dipped his toes into this for the past 8 or 9 months. And he certainly, early in his writing about safe supply expressed his desire to burn the whole system down. So I'm not sure that he's a terribly credible source of information that we want to rely on in this committee. In addition, Mr. Zivo has visited Intercommunity Health Center, where he was actually a very bullying presence to my patients. There is a gate just outside my clinic door that is 3 feet from my clinic door. I'm not finished, Ms. Goodridge.
It doesn't really matter whether you're finished
or not. Mr. Zivo blocked access to health care through the only door to my clinic. I'm sorry, Dr.
Sarita, I think I made you aware very clear of the convention we have in this committee. I really request that you respect that. I've done that with respect to Ms. Goodridge. So, again, let's be respectful today, everyone. Thank you.
Does diversion of safe supply worry you?
I think more important than diversion is the discourse around the diversion that's happening in the media. And so diversion is complicated, and it requires more than a 60-second answer if I can finish.
I appreciate that. I have a very limited amount of time, so I asked really quick, simple questions and wanted simple, quick answers. BC's recently developed some protocols that allow for recreational fentanyl to be prescribed to children in the guise of safe supply. What are your thoughts on this?
I think the BC CSU has very carefully consulted experts, both in who provides addiction care, harm reduction care, and the care of children with substance use disorders. And so I'm not aware that any children have accessed this protocol to date. But if you read the protocol, it is the same as any other kind of complicated health care for children in Canada, whereas 2 experts need to agree. The person needs to be carefully assessed for the risk and any benefit of treatment. And in some children who are dependent on the toxic, illicit fentanyl street supply, Physicians who are caring for them can make expert decisions in
Thank-
what they need for their health care.
So do you think that we should prescribe recreational fentanyl to children?
I think if children are at risk of dying from the toxic street supply, which we know over 90% of deaths in youth are from, which is illicit
Thank you.
fentanyl.
Are you aware that there is safe supply being diverted at Chapman's Pharmacy across the way from your office? Yes or no?
It's not a yes and no answer.
It
I
is
would
a
like-
yes or no. Are you aware or no?
I'm going to decline to answer a
Okay.
complicated question.
Okay, that's fine.
Without being given a
but
chance
do you
for a
deny
complicated
that?
answer.
Okay, that's fine. So you deny that it's happening across the way?
No, that's not what I said, sir. I said I needed time to explain.
Okay. Do you agree that it's possible that diverted opioids are ending up in the hands of people that they aren't prescribed to, or even children? Yes or no?
We have no evidence that they are ending up in the hands of children. We have no scientific data that supports those assertions.
What's the leading cause of death in the province of British Columbia for youth?
It is overdose from fentanyl.
Thank you.
From fentanyl.
Okay, thank you. What is your relationship between the clinic and Chapman's Pharmacy? Is there one? Do you meet with them regularly?
We have a professional relationship
Okay.
because due to their proximity to our clinic, a majority of our patients choose to use that pharmacy. And so we are in nearly constant communication about how to better serve our patients and improve health outcomes.
Do you believe that physicians that prescribe safe supply are morally or legally responsible for diverted safe supply prescription that bear their name?
I believe that every medication that has any kind of value can be diverted. And of course, we
Are you
care about-
morally or legally responsible as a physician for that medication if it is then taken as you prescribe it and then sold on the street?
I am morally responsible for my patients to stay alive.
Okay.
I am morally responsible to care for my community.
All right.
And the suggestion that safe supply clinicians don't care about the larger community is quite frankly extremely
I didn't say that
offensive.
actually. I just asked you if you felt that morally or legally that physicians that prescribe safe supply, are they morally or legally?
Responsibility
Okay.
to our clinic.
Thank you.
The legal responsibility,
appreciate that.
you'll
Thank
have to
you.
ask the lawyers.
A healthcare worker purchased thousands of hydromorphone pills prescribed through your clinic, which led him to escalate his addiction and cause serious harm to himself and his family. What would you say to him, his wife, and his children?
I'd like to know where this anecdote is coming from first.
Well, I never asked you where your anecdotes came from, so I think it's me, again, asking questions. That's my time. Dr. Sarita, how often have community members, including family members of your patients, tried to contact you to express concerns about safe supply diversion originating from your clinic?
Community and family members? Never. We encourage family members to come into our clinic
So
with
at no
their
time
family.
has a patient's family member come
No.
to you? Okay,
No.
okay. Do you support the improved traceability measures of so-called safe supply?
I don't. I think that's a slippery slope around marginalized
Why would that be a
communities.
slippery slope?
We don't put tracers in any other kind of medication.
So can
Why
diversion-
would we stigmatize people who use drugs? Why would we assume that people who use drugs have nefarious intention with their medications?
Wouldn't you
we
want to
know
make
that
sure?
over
Don't you think?
90%.
Can you and I agree that there are many different tools around this table, and there's many different views? But do you not think that we should be doing everything in our power to make sure that we're keeping people safe?
Yes, I do, by
Okay, so
investing in
do you-
evidence-based programs.
Do you believe that traceability would then cause diversion to maybe come down?
No, I don't. I think it would cause people not to use harm reduction programming because this is a group of people who have been criminalized for decades, actually 100 of years. These are people who, on our program, we have 30% Indigenous folks, and we know that is true of most safe supply programs. I don't think anybody who has had a violent relationship with the structures of medicine and government is going to be wanted to be tracked in any way, so it will
Dr.
lead to
Sarita,
death
is
because people will
diversion
not seek
illegal?
treatment. Is diversion illegal?
Yeah. Yes
for
or no?
people to sell their medications, yes, that's illegal, just like they sell methadone.
Okay. Did you receive $1.5 million from the National Safe Supply Community Practice that deems what's their words? They deem diversion as compassionate healthcare?
So I did not receive that money. Certainly the
did your
Safer
clinic?
Supply Community of Practice received that money. I'm aware of the diversion document that you're referring to, and it was written by expert clinicians as well as evidence and advice.
How can you justify that funding, though? If it's an illegal practice?
So I think you're referring to the funding for the Community of Practice, the National Safer Supply Community of Practice. It's not funded to defend diversion. It's funded to support people nationally in learning about safe supply.
Thank you,
helping
Dr.
them in
Sarita. I'm going to have to
practice
stop you
and
there as well.
disseminating
Thank you very
information.
much.
Dr. Sarita, in January 2022, you produced a report that claimed your program was successful because of a 94% retention rate, which is a surprising finding that people with addiction will return for free government-supplied drugs. It was only later during a webcast that when you were asked directly about the other 6% who were no longer enrolled that you acknowledged some of the 16 had died from fentanyl overdoses or from infections acquired from injection drug use. Your study also did not analyze the impacts of diversion. How can you claim that it shows hydromorphone from your program works?
So I think there's always this question of is it the safe supply that is that is making people well, and what we need to know is the outcomes that we are seeing. We compare them to match controls in people who are not receiving a safer supply, and we simply could not see the positive health and social outcomes that we were seeing if people were on mass diversion, as is being alluded to here in this committee. The 6% of folks that we lost were to long-term incarceration, long-term hospitalization, and yes, we have tragically lost some people to infections and overdose. What we do know is that people who are confirmed by urine toxicology to only be using their safe supply, only using safe supply hydromorphone, 0 of those people have died. It is people who continue to engage with the toxic illicit fentanyl street supply that have gone on to overdose. And we know proportionally we've lost so many less.
So it's interesting you say that because you're familiar with Dr. Sharon Koivu. So Dr. Sharon Koivu is a site chief at the London Hospital, former acting medical officer of health. A study by her and Alison McKinley, a nurse practitioner, I'm sure that you're aware of this, examined the charts of over 200 patients who had been referred to Victoria's Hospital Addiction Medicine Consultation Service between January and June 2023, shows that safe supply hydromorphone from your program is causing harm such as serious infections and new addictions. What do you have to say about that?
I have lots to say about that. So I've actually been in communication with Dr. Koivu about this, the data that you just discussed for about 3 months, maybe a bit more, trying to actually find out what her methodology, her inclusion and exclusion criteria.
You're questioning her methodology, is that?
Yeah, because she doesn't release it. This is not a published study. There's no
So that would be
evidence.
anecdotal information as well?
When I have approached her, she's told me she actually cannot discuss any of this with me. Although she can't discuss the findings of her research or just, give her methodology, which all good researchers do, she can release it to Adam Zivo of the National Post, and she can release it on social media. These things don't line up.
Dr.
And when you look at the
has
denominators,
also stated that some of her patients who get safe supply hydromorphone from your program have housing but choose to sleep outside Chapman's pharmacy in tents to be first in line to get the prescription in the morning, which they often sell so they can buy illicit fentanyl. Some of these patients are vulnerable women who are being pressured to secure as much hydromorphone as possible so that their spouses or pimps can confiscate the drugs for resale. These patients also claim that the criminals wait outside the pharmacy and intimidate vulnerable people to hand over the hydromorphone. What do you have to say about that?
I would say that Dr. Koivu tells a lot of stories. Another story
So again,
she is...
You're discrediting another doctor. Is that what you're doing?
I am saying that what she has shared with you is not accurate in my experience. Dr. Koivu has also testified that Safe Supply has a 100% mortality at 5 years, yet she works in a community that has had Safe Supply for 8 years and has 300 living patients. So I think we need to take those reports with a big grain of salt.
So, Mr. Chair, how much time do I have? 1 minute. So Dr. Koivu has also stated that safe supply hydromorphone from your program was present in London before there was much, if any, illicit fentanyl, and that hydromorphone from your program has fueled fentanyl gangs and new addiction.
I really think
you discredit that as well?
I really think that speaks to Dr. Koivu's lack of experience with this population, because that's not true. Fentanyl was present in London, Ontario since 2012, and it really started to pick up in 2013 through 2015, which is why we actually started the program in 2016, because at that point, fentanyl was dominating the opioid sales on the streets of London, and that's why we needed to make a change at that point.
Dr. Samuel Weiss from the Canadian Institute of Health Research testified to this committee on December 4th that based on a study they were conducting on 11 safe supply programs, wraparound supports are critical to any purported benefits from the programs. Given that your program offers wraparound supports, how can you credibly claim that safe supply hydromorphone is providing any benefits?
So first, I think it's pretty funny that, a criticism of safe supply programs is that they give excellent care and excellent wraparound supports, but also the data that I presented to you from the CMAJ study, it was before we had SUAT funding for those wraparound supports. So the data that I reported to you about 50% reduction in emergency departments, admissions, and amount of infections, and 50% reduction in cost was only safe supply prescribing. At that time, we had no wraparound support.